Hello, my name is David Murray. I'm the Associate Director for Prevention and Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the first of three 2024 ODP Early Stage Investigator Lectures. We created this lecture series to highlight early career prevention scientists who have not yet served as principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their respective fields and are poised to become future leaders in prevention research. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions at the end of the lecture. The slides and video recording will be posted on our website in the coming weeks. We're very excited to present one of our 2024 awardees, Dr. Andrea Schneider. Dr. Schneider is an assistant professor of neurology in the Division of Neurocritical Care with a secondary appointment in the Department of Biostatistics, Epidemiology, and Informatics at the University of Pennsylvania Perelman School of Medicine. Dr. Schneider's research program is centered on traumatic brain injury epidemiology and the prevention of TBI-related sequelae, with a focus on the prevention of TBI-related mortality, neurodegeneration, and dementia. Dr. Schneider will present the current epidemiology of TBI, along with efforts focused on improving the characterization of lifetime history of TBI in ongoing prospective cohort studies in diverse populations. Please join me in welcoming Dr. Schneider.
Thank you so much for that introduction and for this award. I'm delighted to be here today to present my work on traumatic brain injury, with a focus on how we can leverage epidemiological data to foster the prevention of traumatic brain injury-related sequelae, with a focus on cognitive sequelae in older age. These are the disclosures for my talk today. And this is an outline of my talk. I'll start first with an overview of general traumatic brain injury epidemiology, and by showing associations of traumatic brain injury with several long-term outcomes. To start, I want to first begin by discussing the definition of traumatic brain injury, or TBI. It's important to note that the definition is evolving. Historically, traumatic brain injury has been referred to as concussion, as mild, moderate, or severe injury, which was based largely on the Glasgow Coma Scale based on physical exam. This past January, in collaboration with NINDS, there was a workshop on traumatic brain injury classification and nomenclature, where a new model was proposed, which incorporates not only clinical information, but also information from blood-based biomarkers, neuroimaging, and psychosocial and environmental modifiers. For purposes of this talk today, we can consider traumatic brain injury as an injury caused by a force to the head, which results in either an injury that is apparent on neuroimaging, or one that results in neurologic symptoms, such as loss of consciousness, post-traumatic amnesia, or altered mental status. Traumatic brain injury is common, and indeed, worldwide, traumatic brain injury has amongst the highest incidence and greatest prevalence of all common neurological disorders. In this graph, we can see that it is more common than stroke, than dementia, Parkinson's disease, and multiple sclerosis. The burden of traumatic brain injury is highest among older individuals, and older individuals represent the greatest proportion of traumatic brain injury-related hospitalizations and deaths. So in the setting of this high burden of traumatic brain injury worldwide, in 2022, the Lancet Neurology published a commission on traumatic brain injury, which was authored by a panel of experts, and it made recommendations to improve the prevention, clinical care, and research related to traumatic brain injury. I want to draw your attention to a subset of their main messages, and these messages were focused on epidemiologic research. These messages are focused on key areas of epidemiologic research that are still needed. Here, they state that there are wide variations in estimates of traumatic brain injury incidence and prevalence, they highlight that some of this variability may be due to study design and analytic choices. They also highlight the limited evidence which exists on milder head injuries and on head injuries occurring among older adults, both of which represent the most common types of injury. So given the high global impact of traumatic brain injury and the research priorities highlighted in the 2022 Lancet Commission on Traumatic Brain Injury, multiple questions remain. For example, how do we obtain nationally representative estimates of the burden of traumatic brain injury and its outcomes? How can we study long-term outcomes after traumatic brain injury when very few studies that were designed to study traumatic brain injury starting at the time of injury have long enough follow-up? And by that, I mean 20 to 30 years or more of follow-up. And finally, how can we gain insights into disease mechanism, which can be used to inform potential future treatments, which are aimed at preventing traumatic brain injury-related sequelae? So I would propose that we can leverage data from ongoing deeply phenotyped epidemiologic studies. So in this talk, I'll focus on two: the National Health and Nutrition Examination Surveys, or NHANES, and the Atherosclerosis Risk in Communities, or ERIC study. But it's important to note that many other existing epidemiological studies have opportunities to also study traumatic brain injury. So next, I'm going to give a brief description of NHANES and of the ERIC study, as much of the data that I will show in this talk will be drawn from these two studies. So NHANES is a series of cross-sectional surveys that are conducted yearly by the National Center for Health Statistics of the Centers for Disease Control and Prevention. Participants are selected using a stratified multi-stage probability sampling design of the non-institutionalized US population. By using survey weights to account for this complex sampling design, we can make the estimates reported from this data nationally representative of this general US population. Traumatic brain injury was assessed among individuals aged 40 years or older during the 2011 to 2012 and 2013 to 2014 survey cycles using one question: have you ever had a loss of consciousness because of a head injury? So in contrast to the cross-sectional design of NHANES, the Atherosclerosis Risk in Communities, or ERIC study, is an ongoing community-based prospective cohort of nearly 16,000 adults who were aged 45 to 64 years of age at study baseline in 1987 to 1989. Participants were recruited from 4 US communities in Minnesota, Mississippi, North Carolina, and Maryland. At this point, participants have been followed for over 30 to 35 years, with very low loss to follow-up. But as expected, there's been significant mortality over this time, with greater than 50% of participants dying. The study has had multiple in-person visits, and currently participants also receive semi-annual telephone calls. Participants have undergone cognitive function assessments at multiple time points over study follow-up, as well as head injury assessment, brain MRIs, amyloid PET imaging, and other outcomes, including death, stroke, heart disease, and dementia. There's also comprehensive characterization of socio-demographic and vascular risk factor variables, which are included in many of our statistical models as covariates. Traumatic brain injury in ERIC was defined as a time-varying exposure, and it incorporates data from both ICD-9 and 10 codes, as well as self-report. The ICD-9 and 10 code data are drawn from active community surveillance of all hospitalizations occurring within ERIC study communities, as well as a linkage to Centers for Medicare and Medicaid data for participants who are enrolled. Using the ICD code data, we define traumatic brain injury in accordance with the Centers for Disease Control and Prevention surveillance definition for TBI, with injury severity defined using the Department of Defense classification for traumatic brain injury severity. The The self-report data on head injury was asked of participants at study visits. The questions on head injury included data on having ever had a head injury, which prompted medical care that was associated with loss of consciousness. They also inquired about the number of prior head injuries, as well as the date and age when these head injuries occurred. So with that introduction to those two key studies, one of the first steps in looking at associations of traumatic brain injury with long-term outcomes with the goal to prevent adverse sequelae is to obtain an understanding of the extent of the problem. We did this by using data from NHANES to estimate the prevalence of prior head injury in the United States. In this study, we reported that an overall prevalence of prior head injury of nearly 16%, which corresponds to nearly 23 million affected non-institutionalized US adults aged 40 years or older. This nationally representative estimate is consistent with other estimates performed in population subgroups, such as on a state level, where the prevalence has generally been reported to be between 15 and 30%. However, it's important to note that this estimate underestimates the full burden in the US, as younger individuals and institutionalized individuals, such as those in nursing facilities, were not included. More recently, we also looked at trends in traumatic brain injury-related mortality in the United States. And although overall, we found that TBI-related mortality was stable between 1999 and 2020, we saw among certain population subgroups, including older individuals, and particularly those aged 75 years or older, that there was a significant increase in TBI-related mortality over time. So while it's been long established that traumatic brain injury can result in mortality close to the time of injury and in short-term impairment and disability, traumatic brain injury is increasingly recognized as a chronic condition with implications for long-term health outcomes. In this recent study, we found a 2 times increased risk of mortality among individuals with head injury compared to individuals without head injury over a median of 28 years of follow-up. The association of traumatic brain injury with mortality increased with increasing number of head injuries and with greater injury severity. Individuals with prior head injury were more likely than individuals without head injury to die from both neurologic and accidental or traumatic causes, as well as from infectious, endocrine and metabolic, and renal causes. We've additionally looked at traumatic brain injury and the risk of stroke. In this study, we used ERIC study data, and we found that traumatic brain injury was associated with a 1.3 times increased risk of incident ischemic stroke over a median of 27 years of follow-up. This risk of TBI with ischemic stroke was similar based on ischemic stroke severity and ischemic stroke mechanism. In another study, which looked among US military veterans aged 18 years or older who were receiving healthcare in the Veterans Health Administration system, we found that traumatic brain injury was associated with a 1.7 times increased risk of incident stroke, here including both ischemic and hemorrhagic stroke, with the association of traumatic brain injury with hemorrhagic stroke being stronger than the association of traumatic brain injury with ischemic stroke. We further observed that the risk associated with incident stroke was highest in the first year post-injury, but that it remained elevated for over 10 years post-injury. In other work, we've investigated associations between traumatic brain injury and physical functioning and frailty. We found that the age-adjusted prevalence of poor physical functioning, as assessed by the Short Physical Performance Battery, was higher among individuals with a prior traumatic brain injury compared to those without. We further observed that individuals with traumatic brain injury were more likely to be classified as pre-frail or frail than individuals without traumatic brain injury. In related work, we investigated associations of prior traumatic brain injury with incident fall risk, and specifically with fall risk that was clinically significant, meaning associated with either emergency department or hospital care. We found that traumatic brain injury was associated with a 1.7 times the risk of fall over a median of 23 years in this study. So furthering this work, looking at functioning after traumatic brain injury, we also have used NHANES data to look at the prevalence of disability associated with prior head injury. In this study, we found that approximately 47% of individuals with a history of head injury, compared to 39% of individuals without head injury, reported impairment in one of these domains of disability. The highest prevalence of disability was seen in mobility and work-related domains. And although less common, we also found significantly higher prevalence of disability related to memory among individuals with a prior head injury. And indeed, the cognitive sequelae of traumatic brain injury have become an important research priority over the last decade. In 2020, the Lancet Commission on Dementia was published, and traumatic brain injury was newly designated as one of 12 potentially modifiable risk factors for dementia. Looking at the population attributable fraction, which is the proportion of cases of dementia in a population which are attributed to a specific risk factor or group of risk factors, and which theoretically could be prevented if that risk factor were eliminated, it was estimated that 40% of all dementia cases are attributable to these 12 potentially modifiable risk factors. And among these, traumatic brain injury had a 3.4% attributable fraction for dementia. So given that traumatic brain injury has been established as a potentially modifiable risk factor for dementia, it is critically important to understand the patterns of the trajectories of cognitive performance after a traumatic brain injury in order to identify key time periods during which interventions may be the most effective at preventing dementia. So this figure shows a trajectory representing aging, as well as two hypothetical trajectories which may occur long-term after a traumatic brain injury. So in the first, the additive trajectory, shown here in blue, there's an initial acceleration in aging, which is followed by a subsequent rate of aging that is parallel to the rate of aging among individuals who did not have a traumatic brain injury. So in this additive effects trajectory, an individual will cross the dementia threshold sooner than a person who is aging without traumatic brain injury, because the head injury led to a decrease in their cognitive reserve. So this trajectory is in contrast to the second, here labeled the interactive effects trajectory, shown in red. In the interactive trajectory, there again is an initial accelerated decline in their cognitive performance, but here it is followed by a continued accelerated rate whereby TBI-related pathology persists and interacts with age-related pathology. And this results in an accelerated cognitive decline over time, as well as a crossing of the dementia threshold sooner. The distinction between these trajectories has important implication for the timing in which future treatments for TBI-related neurodegeneration may be beneficial. So first, I will focus on cognitive trajectories in the early post-TBI time period. And by the early post-TBI time period, I mean in the months to first year post-injury. So data from this early post-traumatic brain injury time period comes from the Transforming Research and Clinical Knowledge in TBI, or TRACK-TBI study. The TRACK-TBI study is an ongoing cohort of acute traumatic brain injury patients aged 16 to 100 years of age, as well as orthopedic injury and friend controls. These individuals were recruited from 18 level 1 trauma centers in the United States. The TRACK-TBI study started in 2014 and recruited nearly 3,000 acute traumatic brain injury patients at the time of injury, as well as 600 controls. Participants were followed for 3 in-person and 1 telephone visit over the first year post-injury and are currently being followed for up to 5 years or more as part of the TRACK TBI longitudinal study. Cognitive function was assessed at every study visit. In this study, we looked at cognitive outcome 1 year after traumatic brain injury, and we reported that 13.5% of traumatic brain injury patients versus 4.5% of controls had a poor 1-year cognitive outcome. We define poor 1-year cognitive outcome as either having cognitive impairment or having had cognitive decline. So in this study, cognitive impairment was defined as a performance falling below a cut point from a normative sample, and cognitive decline was defined using the reliable change index. So interestingly, if we had restricted the definition of poor cognitive outcome to either just cognitive impairment or just cognitive decline alone, this would have resulted in misclassification of our cognitive outcome. So for example, if we focus in on panel A of the figure, the reliable change index of the patients with traumatic brain injury who did not meet criteria for cognitive impairment are shown. And here we can see that 11 participants who had cognitive decline, who are marked in red here, would have been misclassified as having a good cognitive outcome if only cognitive impairment was used to define our cognitive outcome. So these results suggest that an individualized definition, which may incorporate both impairment and decline, may be beneficial in certain studies of post-traumatic brain injury related cognition. Importantly, in our analysis, we also saw a great deal of heterogeneity. But one pattern that emerged was that there seemed to be a subset of individuals who recovered and a subset of individuals who recovered some, but who later had post-recovery cognitive decline. So based on this work from the TRACK TBI study, we can summarize that this early post-TBI time period is characterized by heterogeneity. And while some individuals recover, a subset have a period of post-injury cognitive recovery, which is subsequently followed by post-recovery cognitive decline. So with that, I'll next move on to the late post-TBI time period. And by this, I mean decades post-traumatic brain injury. And I will present data in an attempt to determine if cognitive trajectories in the late post-TBI time period are at a rate parallel to aging or if they are at an accelerated rate. So in this study, we found that traumatic brain injury was associated with 1.4 times the risk of dementia over a median of 25 years of follow-up. We saw evidence for a dose-dependent association, whereby a greater number of traumatic brain injuries was associated with greater dementia risk. In another analysis of ERIC study data, we looked at associations between traumatic brain injury and cognitive decline. And over a period of 30 years, the difference in cognitive decline between individuals with versus without traumatic brain injury was equivalent to individuals with traumatic brain injury being nearly 7.5 years older at baseline. In secondary analyses, we observed heterogeneity in the patterns of cognitive change by traumatic brain injury status by head injury frequency, but not severity, where associations of having 2 or more prior traumatic brain injuries with cognitive decline over 30 years was equivalent to being nearly 10 years older at baseline. Whereas individuals with just 1 head injury declined at a rate similar to individuals without head injury. By injury severity, we observed similar patterns among milder versus more severe injury, but the number of more severe injuries in our cohort limited power for these analyses. So taken together, these 2 studies in the ERIC study suggest that individuals with a history of traumatic brain injury both cross the clinical dementia threshold sooner and have an accelerated rate of decline over time. This suggests that the post-traumatic brain injury related cognitive trajectory is more characterized by the interactive effects line in this figure. We also observed that the post-traumatic brain injury cognitive trajectory appears to be influenced by head injury number. And this motivated us to investigate other factors which may be associated with a greater risk for post-traumatic brain injury dementia. So one area of interest is the idea that comorbid vascular risk factors may be associated with increased dementia risk among individuals with traumatic brain injury. This hypothesis builds on the idea that traumatic brain injury itself is a type of vascular risk factor, given the vascular injury and subsequent ongoing vascular dysfunction which occurs after an injury. So we know that midlife vascular risk factors are associated with later life dementia. And indeed, using data from nearly 16,000 individuals in ERIC, we found that diabetes, hypertension, and smoking were significantly independently associated with increased dementia risk over a median of 25 years of follow-up. So in some preliminary analyses, looking at the 25-year risk of dementia among individuals with versus without TBI and with versus without comorbid vascular risk factors, having a head injury in the presence of at least one comorbid vascular risk factor was associated with a significantly higher risk of dementia compared to individuals without head injury and compared to individuals with head injury in the absence of any vascular risk factor comorbidities. Another area of interest is in looking at the impact of post-traumatic epilepsy. So in this study, we used data from nearly 9,000 ERIC study participants who were aged 67 years or older, and we found that head injury was associated with 1.9 times the risk of epilepsy occurring over a median of 11 years of follow-up. We again found evidence of dose-dependent associations, where a greater number of prior head injuries and greater severity of head injury were associated with higher risk of epilepsy over time. So in further work, we recently investigated associations between post-traumatic epilepsy and dementia risk. Among ERIC study participants followed for a median of 25 years, post-traumatic epilepsy was associated with a 4.5 times greater risk of dementia compared to individuals without head injury or epilepsy. This estimate was attenuated to a 3 times greater risk after accounting for the competing risk of mortality. But importantly, this association of post-traumatic epilepsy with dementia risk was significantly stronger than the associations of head injury alone or an epilepsy alone with dementia risk. So taken together, this work suggests that the late post-traumatic brain injury time period is not only characterized by this interactive effects trajectory, but it's characterized by an accelerated rate of cognitive decline over time, which is influenced in an additive manner by comorbidities, such as vascular risk factors and post-traumatic epilepsy, and likely others. But the question remains, why do we see these patterns of cognitive trajectories after traumatic brain injury? So next, I'll present some work that we've done using biomarker data as an example of one way to gain insights into disease mechanism from epidemiologic studies. So in this cross-sectional analysis of 329 ERIC study participants without dementia, of whom about a quarter had a prior traumatic brain injury, we found that head injury was associated with elevated beta amyloid deposition, both globally, in frontal regions, as well as in the posterior cingulate. The number of head injuries was also associated with greater or more elevated brain amyloid deposition in a dose-dependent manner, globally, as well as in orbital frontal, prefrontal, and superior frontal cortices. I have a recently funded Department of Defense grant, which aims to look at associations of post-traumatic brain injury changes in both MRI and blood-based neurodegeneration biomarkers with dementia risk. So this will include looking at changes in MRI metrics over a period of 8 to 9 years, and changes in the blood-based biomarkers of neurofilament light, GFAP, A-beta 40 to 42 ratio, and p-tau 181 over a period of 25 to 26 years. Importantly, the ERIC study offers the opportunity to look at biomarker trajectories and other features, both before and after a TBI. And this data may help inform if there's a component of a bidirectional relationship between neurodegeneration and TBI, with the hypothesis that subclinical or even early clinical stages of neurodegeneration may contribute to greater fall risk and TBI events among older individuals. The work from this grant has the potential to identify trajectories and combinations of neuroimaging and blood-based biomarkers as high-priority surrogate endpoints and targets for future clinical trials and therapeutics to reduce TBI-related dementia risk. So we first started looking at one time point, and we investigated associations of prior head injury with MRI metrics of cortical thickness, as well as diffusion tensor imaging metrics. So shown here in this figure is the proportion of participants with TBI with cortical thickness z-scores falling below a negative 1.5 cut point for each region of interest. And although at first it appeared that perhaps frontal regions may be more likely to have cortical thinning in this group, there was no clear brain region identified in statistical analyses. And overall, there was evidence of great heterogeneity in the distribution of cortical thinning. So given that, we next performed region of interest analyses where we calculated the proportion of regions of interest which exceeded our z-score threshold for each metric. As we can see on this plot, there were differences in the distribution of the number of regions having cortical thickness scores falling below our z-score threshold. And these were differential by head injury status, with the greater proportion of regions meeting our threshold and falling below it among individuals who had a prior head injury compared to those without. We also performed this analysis on our diffusion tensor imaging metrics and saw similar differences in distribution, where individuals with traumatic brain injury tended to have a greater number of regions of interest falling below what we defined as an abnormal threshold for each region. Furthering this work, we next looked among individuals who had a prior traumatic brain injury who did not have prevalent dementia at the time of the MRI. Here we looked at associations between each of our MRI biomarkers, looking at our cortical thickness and our diffusion tensor imaging metrics and dementia risk over a median of 8 years of follow-up. Individuals who had a greater proportion of brain regions with MRI metrics meeting our z-score threshold had a higher risk of dementia over a median of 8 years of follow-up. In parallel to our neuroimaging work, we've also begun investigating associations of traumatic brain injury with blood-based biomarkers. So in this preliminary work, we can see estimated trajectories from linear mixed effects models for the trajectory of each biomarker shown over time. So we separately looked at pre and post-injury trajectories among individuals who went on to have a traumatic brain injury, and we plotted that separately from individuals who never had a traumatic brain injury. So what we can see here is that we see some evidence of different pre-TBI trajectories in comparison to trajectories among individuals who do not go on to have an incident TBI. And I think this is particularly apparent for the ratio of A-beta. We additionally see evidence that the ratio of A-beta remains lower for nearly 6 years after head injury, and phospho-tau 181 remains elevated for approximately 6 years. NFL and GFAP may remain elevated for up to 10 years after injury. So we'll next be refining our statistical models, and we will be investigating associations of these biomarker trajectories with dementia risk among individuals with a traumatic brain injury. As another way to get at disease mechanism using epidemiological data, We're also starting to work on a large-scale proteomic study for dementia risk after traumatic brain injury using SOMA-scan data in the ERIC study. The overall aim of this project is to determine if the plasma proteomic changes which occur prior to the onset of dementia are similar or different among individuals with versus without a history of traumatic brain injury. We anticipate that these analyses will provide insight into if head injury accelerates ongoing neurodegenerative processes, if head injury represents a distinct neurodegenerative process, or if, as we hypothesize, it represents a combination thereof. So in conclusion, I hope that today I've given data to show that leveraging data from ongoing deeply phenotyped epidemiologic study provides unique opportunities to provide nationally representative estimates of traumatic brain injury, to study the long-term outcomes of traumatic brain injury, and to gain insights into disease mechanism. The data I've shown today provides evidence that traumatic brain injury is common and is associated with significant mortality and morbidity, including cognitive impairment and dementia. I've shown data that the cognitive trajectories after traumatic brain injury are characterized by a period of post-injury improvement, which is followed by post-recovery decline with a continued accelerated long-term decline, which is influenced in an additive manner by comorbidities and factors related to the injury. However, it's important to note that that summary is on a population level, and the patterns of post-traumatic brain injury cognitive trajectories are marked by great heterogeneity. This future work dedicated to the early prediction of patients who will have either good or poor cognitive outcomes will be critically important for future studies focused on disease mechanism, prevention, and treatment. So with that, I'd like to take a moment to thank all of my collaborators over the years, both at Johns Hopkins University and University of Pennsylvania and others, and also to acknowledge my own funding support as well as the funding support for the studies that I showed in this talk today. So thank you so much for this opportunity. I put my email here. I am always interested in talking with people who are excited about this type of work. So please reach out to me if you have any questions or are interested in collaboration. And I'm happy to take some questions now.
Thank you, Dr. Schneider. Very interesting webinar. And let's jump into some questions. One of your early slides showed that the burden of TBI in terms of, I think it was hospitalization and mortality, was highest among older adults. Is that because older adults are more likely to experience TBI, or is it due to long-term effects of TBI experienced in those individuals at an earlier age?
So I think it is because I think there's a couple of reasons, right? So our population is aging. There are more older adults than ever before. So compared to 20 years ago, a greater proportion of our population is, say, older than 65. So I think that's one thing, just that there's more older individuals. I think that many of the hospitalizations and mortality is related to acute injury. We know that older individuals have the highest incidence of traumatic brain injury, and most of them are related to falls. The greatest proportion of traumatic brain injuries occurring in older adults happens due to falls. And that's why I think some of the data that I showed looking at physical functioning and frailty is so critically important, because I think that this really speaks to this bidirectional association that we're seeing in older adults, whereby if you have greater frailty, you're more likely to fall, which also impacts your frailty and worsens your physical functioning. And it's a cycle that I think older adults are getting into, leading to the significant morbidity and mortality.
Thank you. Does concussion count as a TBI? And what do we know about concussion in childhood or adolescence and long-term cognitive effects?
Yeah, so really good question. So I will admit that I am not a sport-related concussion investigator, although I am starting to look at some of these studies to leverage some of the longer-term follow-up. There has been a lot of work looking at sport-related concussion and specifically chronic traumatic encephalopathy or traumatic encephalopathy syndrome, which is the clinical syndrome versus a pathologic diagnosis. And I think that there is real signal there. Now, does that mean that nobody should participate in contact sports or anything like that? Absolutely not. And I think one study that I didn't include in this talk because it's very preliminary, but when I was talking about risk of stroke, we've actually started doing some interesting work using Scottish national data. And on a population level, we see the same increased risk as I showed in this talk. However, among a cohort of former professional footballers, we see no increased risk. So I think that there's a lot to be said about the positive aspects of sport, which may mitigate some of the adverse sequelae that we see. And I do think that this question gets at overall, as I presented, there's 12 modifiable risk factors that were identified by the Lancet Commission on Dementia. And many of those, things like diabetes, blood pressure, many of these are things that people can actively modify on a day-to-day basis, right? You may not be able to go back in time and prevent a head injury from occurring, but head injury is not the only factor that plays into later life outcomes and specifically cognitive outcomes. So when I see patients in clinic and in the hospital, I often encourage them that really focusing on the modifiable risk factors that can be changed on a day-to-day basis, that will overall reduce risk.
And that gets at one of the prevention messages. We may not be able to prevent people from having a TBI, but I think, if I heard you correctly, the advice that you would give such individuals is focus on managing blood pressure, focus on managing weight, focus on exercise, focus on alcohol consumption, the other modifiable risk factors in that set. Because your data showed that if they've got the TBI and those things, they're worse off than if they just have the TBI.
That's exactly right. And I think that it also, it's motivating. I have a lot of, I've seen many former athletes who are very, very worried by some of the press coverage, right, of studies. And I think that it can be motivating and give people kind of the feeling that they have control over an aspect. And, this is not to de-emphasize the importance of both primary and secondary prevention of traumatic brain injuries themselves, right? So things like wearing helmets, wearing your seatbelt, all of these types of things are critically important too.
Given the need for decades of follow-up to study TBI and the long-term sequelae of TBI, please comment on the potential recall bias from self-report of TBI. Has the question of head injuries that were associated with emergency room or hospital visit been validated in any way?
Yeah, so that's a great question. And I think that in order to get at lifetime history of traumatic brain injury, the only way to do that, at least in the United States, and even in other countries where there are, national healthcare systems showing all healthcare encounters, but the only way to really get at lifetime exposure is by self-report, because not all traumatic brain injuries result in individuals seeking medical care. And I think that this is one of the big challenges in traumatic brain injury is getting good ascertainment of the exposure. And so there's been several validated questionnaires that get at how do you define a TBI? How do you define lifetime history of traumatic brain injury? One of those is called the Ohio State TBI identification method. And I think one unique thing about this is that it asks about traumatic brain injury in many different ways. So if I say traumatic brain injury to somebody, that may mean something different. Some people don't think of concussion as a traumatic brain injury. Some people don't recognize that they've had a traumatic brain injury. So the way that this validated questionnaire works is that it uses phrases such as, had your bell rung? Have you had been knocked in the head? Have you, using these different ways of talking about this spectrum of injuries helps to get people to understand the kind of underlying construct that we're trying to study here. We are actually currently working on a validation study. In the ERIC study, we're getting hospital records, and we are looking through the admission notes, the discharge summaries to try to validate the ICD code part of the definition. But I would argue that relying on self-report is really the only way to capture the more mild injuries. And that's what the 2022 Lancet Commission is getting at, is that something that's been missing from many of the existing traumatic brain injury studies is these more mild injuries where people perhaps don't present to medical care, but there may still be some long-term sequelae.
Looking at TBI patients, can early neuro rehab significantly influence the extent of disability in the long run?
Yeah, so I think traumatic brain injury, similarly to stroke, early rehab can be really, really helpful, particularly after significant traumatic brain injuries. There's some literature drawing more from the stroke world, where you may see kind of the greatest increase in your recovery within the first few months. But there's a lot of data, especially new data coming out of very severe injuries, those that result in coma for weeks to months on end, showing that people can recover for years post-injury. And I think that when I showed the schematic with the interactive trajectory, when I was talking about cognitive decline, and I provided data showing that I think that what happens after a traumatic brain injury is more similar to this interactive effects. What that suggests to me in terms of timing is that it's not only that you have to intervene early. It suggests that there is hope that we can still stop or slow ongoing processes that are accelerated over time. And so I think that that's hope for people with long-term effects of traumatic brain injury.
It was interesting that in, I think it was the ERIC data, you found that multiple TBI, and correct me if I misunderstood this, you found that multiple TBI were more harmful than a single but more severe TBI. And one would expect that both the number and the severity would be important. Have you been able to look at the interaction between those two factors and tease that apart?
Yeah, so that specific data is in relation to when I showed the 30-year cognitive decline data, where we didn't see difference between more mild versus more severe traumatic brain injuries. I think, one thing that's really important to note is that prior studies have actually shown an interaction between age and severity. And because the ERIC study has a 20-year age range, and the time of the data that I was showing is all among older individuals, this is actually consistent with other studies who had a wider age range where they didn't see any difference by TBI severity among older individuals, but they did by younger. So I wonder if our results are actually representative of just that, the fact that age and severity there may be an interaction there. Unfortunately, getting at the question of TBI severity and TBI number, when we start stratifying, if you've had 2 or more severe injuries or 2 or more mild injuries, we start getting to smaller numbers, even though the overall cohort is quite large. So limited conclusions can be drawn there.
Thank you. Here's a question about ERIC, rather generally. You said that ERIC participants were recruited from 4 sites. I think all west of the or east of the Mississippi, or not far west. What if an ERIC participant was on vacation in California and had a TBI? Would that be captured in the ERIC data collection process?
Great point, and it would. So earlier in the study, we did annual telephone calls. Later in the study, and now the participants are having twice a year telephone follow-up calls. Part of the questions that are asked on these calls include, have you been hospitalized? And if so, they ask where. If a participant was hospitalized in a community that is outside of the active surveillance that's being done, our study team gets their hospital records. And so we have hospital records from presumably very close to all that occurred in the study among study participants.
You haven't said much about differences that may be observable in terms of sex, in terms of race, ethnicity. Are these factors that what's the diversity in the samples that you have is the first question, I guess. You've talked about in Haynes, you've talked about ERIC, you've talked about track TBI, I think it was.
Yeah.
How diverse are the samples, and have you looked at sex differences? Have you looked at differences by race, ethnicity?
Yeah, this is a great question, and something that's really important. So in NHANES, we can start there. We certainly have basically a representative sample of the US population. So we have men, we have women, we have all races, ethnicities. And so overall, if we're talking about traumatic brain injury prevalence, traumatic brain injury is more common among men. It is more common among white individuals as compared to racial or ethnic minorities. When looking at associations, we have seen some differences largely by race in associations with dementia, where we saw stronger associations actually among white individuals than among Black. And in our paper, we hypothesized that it may be because Black individuals have a higher baseline rate of dementia due to a variety of other mainly social related or vascular risk factor related factors. So the absolute risk starts out at a greater level there. So perhaps the additional risk that is attributable to traumatic brain injury has less of an influence among certain population subgroups. But in each of our studies, we do look specifically for any interaction by age, sex, race, many times ApoE genotype status, where we've seen stronger associations among individuals who've had one or more ApoE genotype.
Thank you. So TBI are more common among males?
Yes.
Yes. This is consistent with something I learned from my wife, who did her rehab psychology residency at Harborview in Seattle. And she asked one of the senior nurses, what are the major risk factors as she's looking at all of these patients who are there from a variety of things? And the nurse turned to her and said, testosterone.
I will say though, the sex differences in traumatic brain injury are actually related to age. So among younger people, it's certainly among males. Among older people, the sex differences in TBI incidence essentially go away by the time you're 65 or 70. And so among older age, men and women have approximately the same risk of having a traumatic brain injury.
All right, thank you. Do you have suggestions for the mechanism by which TBI is associated with elevated amyloid?
Yeah, I think that there's a whole lot more to be parsed out related to underlying mechanisms that relate traumatic brain injury to dementia risk. While we did see signal with increased beta amyloid deposition, one thing that we know about amyloid deposition is that some people may have a lot of it and not have any clinical signs of dementia. So it's not necessarily specific. We don't have tau PET in ERIC. That would be something that could be of interest, although tau PET in other studies has not necessarily been shown to be associated always with traumatic brain injury. I think that another really interesting hypothesis regarding the association of traumatic brain injury with dementia is getting at vascular changes. Because when you think of traumatic brain injury, many times you either have a large contusion or other type of significant vascular injury. But even if you don't have that, you have microvascular injury. And I think that tying this together in terms of talking about traumatic brain injury as a type of vascular risk factor, that's actually kind of my leading hypothesis. As for the associations, not necessarily so much it's beta amyloid dependent or anything like that. But I do think that the amyloid is probably a downstream effect of the ongoing neurodegeneration and changes that we see after traumatic brain injury. But I think that I am most excited about these potential vascular factors, which may be at play.
Now, Eric, I'm certain, has samples in the freezer.
Yes.
And you could go back and look at biomarkers that aren't currently available to you. It's just a matter of an ancillary study proposed and NHLBI coming up with some funds to support that. Is that something that you're thinking about?
Yeah, so my last kind of slide, the future directions, looking at large scale proteomics. So we currently have what's called SomaScan data, which is in essence a exploratory proteomics. It has over 5,000 proteins, and we're going to start there because it's existing data. We have it measured at multiple time points, and then potentially based on that work, identify some key targets that we may want to go back and use some of the stored samples to measure. The other biomarker data that I showed on neurofilament light and GFAP and the phospho-taus, that's something that as a study we're also going to be expanding in ERIC. So right now it's been done in a subset of participants, and we're really excited to be able to go back in coming years to measure it in all ERIC participants.
One of our questions was about the biomarker association. How do you get pre-injury data from patients? How many time points of biomarker data exist in ERIC?
Yeah, so this is a great question. So biomarkers currently we have measured at 3 time points over a span of 25 to 26 years. One of the great things about ERIC is that we have data both pre and post traumatic brain injury, but also one of the really, really challenging things about analyzing this ERIC data is taking into consideration when in relationship to biomarker measurement, the traumatic brain injury occurred. So studies like Track TBI, which start their follow-up at the time of traumatic brain injury, have a very nice, clean starting point. But they certainly don't have data, particularly biomarker data, that occurs prior to the injury, since they're enrolled at time of injury. Because ERIC was not designed to study traumatic brain injury from the start, I have traumatic brain injury as a time-varying variable, meaning that I know when it happened. And for some participants, it happened before the first biomarker measurements. For others, it happened in between the first and second. Others between the second and third, and others after all 3 biomarker assessments. So we are working on our statistical modeling to take into account how far between biomarker measurement and TBI in order to model these trajectories. It is certainly challenging, but I think a lot of opportunity is here.
Well, I would love to talk more about the statistical models and the developments there. That happens to be a particular interest of mine. But we are out of time. And have not been able to get through all of the questions, of course, but I want to thank you, Dr. Schneider, for a terrific presentation. I want to thank our audience for great questions. As I mentioned earlier, we will be posting the slides and a recording of today's presentation on the Office of Disease Prevention website in the next few weeks. And those of you who registered for the webinar will get an email when that material is available. Thanks everyone for joining today's Early Stage Investigator lecture. Thank you.
Thank you so much.